Good evening. This is Dr. John Bennett, televising from Miami for Neurosurgical TV in collaboration with Deepak Gupta for Department of Neurosurgery of the AIMS Hospital in New Delhi. Today we have the pleasure of having Manas Panigrahi, MD. He's going to talk about endoscopic management of hydrocephalus. But first, let me briefly introduce the panel. Hello, Deepak.
Hello. Good morning. Good morning, Dr. Manas.
Good morning.
We are very happy that you agreed to join us at this platform. And this is a very innovative and a unique concept of educating the doctors all over the world. Many doctors may not be available online to talk to you now, but some of them are watching, and this program is being live streamed to different channels. And the beauty of this thing is that the people will be able to see what you talk now as an educational video for a very long time on YouTube. And I must say that Dr. Manas Panigrahi is a very accomplished and a fine neurosurgeon and from India, and he has got a huge amount of experience in endoscopic procedures. And we look forward to listen to you, Dr. Manas Panigrahi, and thank you very much once again for joining us.
Very good. Natararan, can you introduce yourself, please?
Yeah.
Hello, Natararan. Could you please introduce yourself? Can you hear me okay?
Dr. Muthukumar?
Oh, I guess not. You're muted. Could you introduce yourself, please? You're muted. You're muted. Okay.
I'm just. Are you able to hear me now?
Yeah. Okay. Yes. Could you introduce yourself, please?
Yeah. I am Dr. Muthukumar. I am the professor and head of neurosurgery at Madurai Medical College, Madurai. I have a special interest in pediatric neurosurgery, and it's great to be a part of this panel. Thank you.
Great. And Chandrasekhar, you just arrived. Can you hear me okay? Can you introduce yourself? I guess not. I guess maybe we'll wait till later. Okay, Manas, thank you for being. Okay, are you there now?
Yeah, I'm ready.
Yeah, could you just say hello?
Hello.
Dr.
Can you hear me?
Okay, Manas. Sorry we're late. Go ahead. It's all yours.
Okay. Can you hear me?
Yes, I can.
Okay. So thanks Dr. Deepak and Dr. Muthukumar, and thanks Dr. John for making this possible. This is a channel where we can speak at our own convenience, and the learners also can learn at their own convenience. Even if they are not there, as it's available in YouTube, it's be used by many people. My topic is on endoscopic management of hydrocephalus. We have been doing endoscopy since 2001. Over the years, we have learned when to do and when not to do. So I'll take case examples of the cases which we have done, and then and give principles for the upcoming neurosurgeons or training, that which are the right cases to do to treat hydrocephalus in endoscopic way, and which are the right cases to do a shunt. Now this is how we manage. If a child comes with hydrocephalus, with dilatation of the lateral ventricle and third ventricle, the first thing if this child had come in like in 1910, we would have thought of doing endoscopy. Endoscopy is not a new method of treatment. It's an old method. Like many diseases of neurosurgery which are treated, like if you take Parkinsonism, it started with surgery, then came medicine, and then again surgery has crept into it. Even in epilepsy, it started with surgery, then we had a lot of anti-epileptics, again now surgery has crept in. Similarly, in hydrocephalus management, the first thing to was an endoscopy, but then it was not popular as the equipment was not very good. So if a patient came in 1910 to till 1940, people still used endoscopy, and John Mixter was the first to do a endoscopic third ventriculostomy in 1923. It is in 1952 when speech first came with using the VP shunt. And this, after 1950, people were a little skeptical of endoscopy as the results were not so good. Until recently in 2000, there are a lot of papers came in 2001, 2004, and 5 where they demonstrated that third ventriculostomy, endoscopic third ventriculostomy was superior to ventricular peritoneal shunt, especially whenever there is hydrocephalus associated with tumors. And this was possible because we had newer imaging modalities, we had a better camera, better endoscope, so the visualization was better, and hence the complication came down. In 2007 and till now, 2016 also, there are a lot of papers have come comparing whether which is superior, whether endoscopic or ventricular peritoneal shunt. No one, when endoscopy came, it was promoted as that endoscopy is the panacea, not it is the gold standard of treatment. But the failure rate of endoscopy is almost 26% or 30% in 3 to 5 years. And similarly, the failure rate of VP shunt was 42%. So, in the conclusion of this paper was endoscopy was better than VP shunt. Similarly, there was another paper by Kulkarni et al. When it was done by the Canadian Pediatric Neurosurgery Group. When they compared the role of endoscopy versus shunt, they found that the risk of surgery was higher in the initial 3 months in endoscopy, but then over 2 years, the failure rate is half to that of, as you can see in the other paper also. So if you see these two papers, it appears that endoscopy is superior than shunt. But then endoscopy is not the right treatment for all the cases. So if a patient comes, how to decide that which is a case for an endoscopy? Now this can be done by using a ETSS score, which was published by again Dr. Kulkarni in 2010. Now what he took is he divided them into took the age and the etiology and the previous history of shunt. Now, if the age was less than 1 month or 1 to 6 months, it was score was 0 to 10, and if there are previous shunt was there, it's 0, and no previous shunt is 10. So when you add up all these 3 scores, whenever the score was more than 80, then the success rate of endoscopy was higher than the shunt. So these group of people will be benefited with endoscopy. Whereas whenever the score was less than 70, then shunt and endoscopy had similar results. So and if the child is less than 6 months, shunt was superior. So it's not essential that any child comes with hydrocephalus, they have to be treated with endoscopy. One has to do a proper evaluation whether he had a previous shunt or not, what is the etiology of the hydrocephalus, and what is the age of the patient. Depending on that, decide whether the child is better to undergo endoscopy or a shunt. Now, once we decide for a particular child to go for endoscopic shunt surgery, I'll show a small video of how to do the endoscopic shunt surgery. Now, the first step in planning an endoscopic third ventriculostomy is planning the proper burr hole. Because if you miss the burr hole, then one cannot enter the foramen Monro in the right angle, and there are chances of damaging the fornix or the thalamus-striate veins. So the first one has to study the sagittal image of the child, then draw a line from the tip of the dorsum through the center of the foramen Monro and project it onto the skull. Wherever it reaches, that is the point where one has to make the burr hole. And then when one enters through that burr hole, as you can see in the diagram, we can do a third ventriculostomy without damaging any structures. So once you have it projected on the MRI, one can measure the distance from the nasion to the projected line and plan the burr hole at that place. It's not essential that all the time you do a pre-coronal burr hole, as many children come with a deformed head, and using a standard burr hole may land up in problems. Before doing a third ventriculostomy, it's essential to know the anatomy of the floor of the third ventricle. So the floor of the third ventricle, if one goes from the anterior to posterior, it starts with the optic chiasm, then you have the infundibulum of the hypothalamus, then you have the tuber cinereum, then you have the mammillary bodies, and then the posterior perforated substance and midbrain. Now, the third ventriculostomy is done in the pre-mammillary area. One can see that just in front of the mammillary body, the top of the basilar artery also is situated. So while making a hole, one is to avoid the basilar artery. Always make a perforation in front of the basilar artery to prevent vascular damage. Similarly, if one looks from the floor of the third ventricle, like this is the mammillary bodies, this is the pituitary stalk, and this pre-mammillary area is the safe zone. So in front of the basilar bifurcation and behind the infundibular recess is a safe zone where one needs to do the third ventriculostomy. As you enter the lateral ventricle, the first thing you see is the foramen of Monro. The foramen of Monro is bounded by the fornix anteriorly and superiorly, and one identifies the choroid plexus, one identifies the thalamus-striate vein and the septal vein. If one follows the choroid plexus and septal vein, wherever it joins, one reaches the fornix. If as you enter the third ventricle, if you do not identify the foramen of Monro, follow the choroid plexus anteriorly, and wherever it joins the thalamus-striate, in front of it, you'll find the foramen of Monro. Usually it is done in a supine position. The head is kept at 20 degrees elevation. The operating table is kept at a lower level so that you can place the endoscope and work comfortably, and look at everyone has to look at the ergonomics of the surgeon also. And the burrow is planned, as I have already explained. Draw a line from the dorsum celli through the center of foramen and project it onto the skull. This is an endoscopic. This is a video of a third ventriculostomy, where as soon as you enter the ventricle, you see the choroid plexus, the septal vein, the thalamus-striate vein, and then enter the foramen of Monro. Usually, a 0-degree endoscope is used, which is 4 mm diameter. As you enter, pass through the foramen of Monro, one will identify the floor of the third ventricle. Now, this red-colored dot is the infundibular hypophysis, and this ridge is the dorsum celli. These two ovoid except structures are the mammillary bodies, and these two structures, red color pulsating structure, are the tip of the basilar artery with the bifurcation. The safest area is in front of the basilar artery and behind the dorsum celli or the infundibular hypophysis. Once you make a perforation, one has to dilate the foramen using a Fogarty catheter. Now, the perforations can be done with a sharp instrument, with a Caesar or endoscope itself, or the Fogarty catheter. While dilating the Fogarty catheter, it's better to keep for 1 minute so that you achieve hemostasis while removing the Fogarty catheter. Once the hole is done, minimum 5 mm dimension has to be achieved. One has to pass through the osteotomy, see that one sees the basilar artery and the bifurcations. As many times one can find a second membrane, and if one does not perforate that, there is a high chance of failure of third ventriculostomy. It's not easy all the time like this to perforate the membrane. Like in chronic hydrocephalus or a post-meningitic hydrocephalus, as you can see in this video, it does not. Yeah, it is not easy to perforate as we do. If the Fogarty catheter, you cannot perforate with the Fogarty catheter, then one can use Caesars or bipolar. And some people use ultrasound also to suck. So here it was difficult because the floor of the third ventricle was thick. And it's opaque also. Many times it's not seen where is the basilar artery. In these cases, one can use an ultrasonic Doppler if one has, or use to, if you do not have a Doppler, one has to do the perforation directly on feeling the dorsum celli. Cutting on the dorsum celli, one is safe and you can avoid damaging the basilar artery. Once you perforate with the Caesar, the osteotomy can be enlarged by a Fogarty catheter. the Fogarty balloon has to be dilated gradually, kept for 60 seconds to 20 seconds, so that there is hemostasis is achieved. And you can see here, after dilating the floor of third ventricle, still there is one more membrane inside. We do not see the vessels here. So in these cases, one has to perforate the second membrane also. The success depends on visibility of the naked basilar artery like this. So if one sees the basilar artery, the success rate goes to 80%. In 2001 and 2000, we had published the microcerebral anatomy of the liliquist membrane in relation to the endoscopic anatomy in minimal in 2000 and 2001. The liliquist membrane, which forms the second membrane, has two sheets. One has a diencephalic membrane, one is a mesencephalic membrane. Now this shows the diagram that this is the liliquist membrane. It goes from the dorsum celli to the pre-mammillary area till the mammillary body. Now and this has two sheets. The second membrane can go from the dorsum celli to the midbrain of the tectum. So when even this membrane is very thick, then the CSF, even if one makes a hole here, CSF doesn't come down to the cistern. So one has to perforate the floor of third ventricle as well as perforate the liliquist membrane if it's thick. And if there are two membranes making a perforation behind, again there will be a failure of endoscopy. So one always has to make in front so that the basilar artery is seen. If you can see the naked basilar artery, that means you have done the perforation of all the barriers of all the membranes. It is the concept of third ventriculostomy came as we thought that there are no neural structures in the floor of third ventricle. Now, there was a paper in 2012 where they did histological analysis of the third ventricular floor in non-hydrocephalic patients and hydrocephalic patients. Now, what they found was that they compared 5 cadavers with hydrocephalus and 5 cadavers without hydrocephalus. What they found was that the number of neurons or the cell bodies are similar whether it is hydrocephalus or non-hydrocephalus, and the floor of the third ventricle or the pre-mammillary area is not devoid of neuronal cells. There are some cells. And whenever one makes a perforation, because of traction, one can damage the nuclei in the lateral wall of third ventricle, and this can cause potentially complications in the surgery. All of us know that endoscopic third ventriculostomy has a chance of developing diabetes insipidus. They can develop memory disturbances due to pharyngeal injury or damaging the nuclei also. Now, if one performs the third ventriculostomy anteriorly, they can cause diabetes insipidus. They can have thermal regulatory disorders and cardiac arrhythmia. Many of us have experience of bradycardia while doing the third ventriculostomy. Even if the perforation is posteriorly, there is a higher risk of personality disorders, memory disorders also. In addition to do third ventriculostomy, hydrocephalus management also involves treatment of the primary cause. If you have aqueductal stenosis, one has to do an aqueductoplasty. And if you have a tumor, one has to take care of the tumor. And if you have a cyst, one has to take care of the cyst. My consequent slide will be on the management of the etiology. I told now the symptomatic management, diversion of CSF. Now I'll be talking about the management of the etiology of the hydrocephalus. Now this is a video again of the third ventriculostomy. The anatomy is clearly seen. The bifurcation of the basilar, the mammillary bodies. I pass in the endoscope posteriorly and identify the aqueduct. Here you can see here the aqueduct is sorry. Here the foramen mater is quite wide, and the septum pellucidum is absent.
Are you okay, Manas?
Yeah, I'm okay.
Okay.
Is it coming okay?
Yes.
Now,
Yes. Good. Good picture.
puncturing the aqueduct uh, with the monopolar, and it was very tough. You see the posterior fissure, the suprapineal races, and then doing an aqueductoplasty with a Fogarty catheter. As we know that the diameter of the aqueduct is 2 to 3 mm, while in inflating the Fogarty, one should not do it more than 3 mm diameter, otherwise it can cause gaze paralysis. Now this is another case of hydrocephalus due to a cysticercal cyst, where the cyst had migrated from the third ventricle. When I did an MRA first, it was in third ventricle, but when I did an endoscopy, it had migrated into the fourth ventricle. So we had to do through the aqueduct. We are extracting the cysticercal cyst with just a suction aspiration technique. This is a standard central venous line we are using as an instrument to hold it. And the cyst is punctured and delivered out through the aqueduct into the third ventricle. And you can see the aqueduct is empty now. And the cyst is along with the endoscope, it is pulled out into the for biopsy. Now, what does one do for tumors associated with hydrocephalus? Now, if one has a pineal tumor with hydrocephalus, one can do a third ventriculostomy as well as a biopsy of the third ventricle of the tumor. But the prerequisite is the third ventricle should be wide. As all for endoscope sheath is almost 6 mm, it is important that the width of the third ventricle should be minimum of 6 mm, and the width of the foramen Monro also should be 6 mm to plan a biopsy procedure. If it's narrow, or the third ventricle is narrow, or the foramen Monro is narrow, then it's probably better to avoid endoscopic third ventriculostomy. So this is another 42-year-old a female who came with ocular signs with unsteadiness of gait, and the scan showed a posterior third ventricular tumor with wide third ventricle, more than 6 mm. That is the prerequisite. And the foramen Monro also should be wide before one plans a biopsy. And I can see here the foramen Monro is wide. So then these are the right cases for doing third ventriculostomy and biopsy together. When I did an endoscopy, there was already a spontaneous third ventriculostomy in this patient. And then we went back to identify the tumor. You can see here the interthalamic adhesion. Here the tumor is seen bulging in the posterior part of the third ventricle. The aqueduct is anteriorly like a crescent shape. Instead of using monopolar or bipolar to coagulate, you use the Fogarty catheter as a hemostatic agent also. We insert the Fogarty catheter into the tumor and then inflate it. If you inflate, it acts like a Caesar, like opening up the tumor, and automatically it has achieved hemostasis also. You can see here, you're just waiting for the right angle to enter into the tumor and then inflate the Fogarty catheter. Try to reduce the number of instruments, like one can use monopolar, bipolar to coagulate, but it increases the time, the number of instruments used. So with one Fogarty catheter, it helps like a Caesar, like a hemostatic agent. Once you insert Fogarty catheter, then again we widen the balloon, dilate the balloon. This is the aqueduct, this is the posterior intercommissure. And you can see here the tumor, there is no bleeding. The tumor, the ependyma is open, and now it is easy to take a biopsy. You take the biopsy forceps. Here, cut incise the interthalamic adhesion to have an access. And then biopsy is taken. And if there is bleeding, again, Fogarty catheter can be used and inflated there to achieve hemostasis. This turned out to be a germinoma. Now, these are cases where you can do without navigation. There are few cases where navigation is useful in endoscopy, especially when you have a narrow foramen of Monro, or you have asymmetric skull and ventricle, or suprasellar arachnoid cyst, or one plans two procedures like third ventriculostomy and biopsy, or when the floor of the third ventricle is thick, like in post-meningitic hydrocephalus or a chronic hydrocephalus, in multiloculated hydrocephalus, or biopsy of paraventricular tumors like thalamic tumors or caudate tumors. And I'll take examples of these cases. So normally we calculate manually the burr but if one uses navigation, one can always use the reference pointer to plan your burr and trajectory. But normally, usually, you don't do it regularly. Now, this is a case of a post-meningitic hydrocephalus. If in a cases of post-meningitic hydrocephalus, we normally get a contrast MRI in all the patients. And if the floor of the third ventricle is enhancing, you can see here that it's thick and enhancing, then one can predict that during surgery, it will be very difficult to perforate. And these are the cases we try to use navigation to find out the basilar artery. And these are the cases we try to avoid doing surgeries also, as if the floor of the third ventricle is very thick, then for the success rate of third ventriculostomy comes down drastically, unless the patient is explained that the success rate will be less, but if they insist on surgery, we do third ventriculostomy in these cases. So it's essential to do contrast MRI in post-infectious third hydrocephalus. Now this is another girl who came with the hydrocephalus due to suprasellar arachnoid cyst. Now you can see here the arachnoid cyst, and in the side set you can see the bulging arachnoid cyst into the lateral ventricle also. The procedure what we plan is to do a cystoventriculostomy as well as do a cystocernostomy. Now most of the time, then once you do a cystoventriculostomy and enter the suprasellar cyst, the floor of the third ventricle is very thick. It's very difficult to identify the basilar artery or the mammillary body, and so in these cases again navigation helps us to plan where to make the cystocernostomy. Sometimes we do the MR angiogram and we superimpose the MR angiogram on the navigation, so that it helps us in the navigation can help us to avoid the basilar artery here. You can see here the basilar tip of the basilar artery, and then can plan the perforation in front of the basilar artery. Now this is a video of the same case where we enter the lateral ventricle. We have already punctured the cyst. You can see here the cyst is punctured, the it's collapsed, and the next step is to, you can see here the aqueduct is seen because the cyst is punctured, the third ventricle is open. But still, we wanted to prevent recurrence of the cyst. Wanted to do a cystocernostomy. Here you can see that for the floor of the third ventricle, it's coming into the third ventricle. You're checking if the aqueduct is patent or not. And next step is to find the cystoventriculostomy. Through that, we are entering the cyst. We enter the suprasellar cyst. This becomes a difficult task as if the cyst has already collapsed. Many times it becomes difficult. So one has to have a little bit of patience. Fortunately, in this case, the floor of the third ventricle was easily, you can see here the floor of the third ventricle thick membrane which are perforated, and you can see the pons beyond the floor of the third ventricle. There is still another second membrane which are trying to perforate. till we do it till we find the basilar artery. The other indication of doing navigation is multiloculated hydrocephalus, like in this case. And once you do a navigation, you can plan the septostomy, and you can be sure of doing that you have communicated all the loculi. Otherwise, if you do not do navigation, it is like presumptive evidence that we have communicated all the loculi. The other indication is biopsy of tumors, like these tumors of the thalamus or the pulvina, where the third ventricle, also the anterior part of the third ventricle is open. In this case, we did a third ventriculostomy as well as did a biopsy of the thalamus, so that we avoided a second procedure of doing stereotaxy biopsy, and we didn't do a shunt also. So one single procedure of third ventriculostomy and biopsy of thalamus, and depending on the biopsy report, we went ahead giving radiation for this patient. Now, in adult patient, one can use the optical, but in the optical with shear track, one needs to fix the head. In children, we use the electromagnetic EM system, the axiom system of Medtronic, and so that one need not fix the head, and if shunt is required, it can be done easily. This is how we place the patient. If we plan to do in multiloculated hydrocephalus to communicate all the cyst and the cistern, so in the EM system it becomes easy. We can fix the reference frame or fix with a sticker also. The shunt tube tracker which they give to insert a shunt, this is not FDA approved, but they use the shunt tube tracker inside the shunt, and then automatically our endoscope becomes like a navigated endoscope. You can see here it works like a navigated endoscope. So this is how the endoscope. This is an irrigation channel, this inflow channel, outflow channel, and you have the shunt tube tracker in it, so that one can track the endoscope and do the perforations as and when required. Again, this is the intra pictures. As you enter, it directs us where you have entered and where to do the perforation. Now, this was a case of asymmetrical lateral ventricle dilatation. You can see here the septum is pushed to the contralateral side. This is a case of a foramen Monro block. So here we planned septostomy, and we used again navigation, so that we confirm that they have entered the opposite ventricle also. And you can plan the septostomy point also. This is a video of a septostomy. Yeah, the video doesn't open.
Okay, try clicking twice.
Okay.
Didn't work.
Yeah, it doesn't work.
Okay.
Okay, maybe at the end of presentation I can go back to the source file and so.
Okay.
Yeah. So as I explained you, in patients with narrow foramen of Monro, like this patient who had a posterior third ventricular tumor, and the floor of the third ventricle also is thick, and in addition the foramen of Monro was very narrow. In these cases, navigation helps, and if still during surgery you find that it's inadequate, then one can use a pediatric endoscope, and if still it doesn't work, it's better to come out rather than damaging the fornix or causing any bleeding from the thalamocaudate veins. If the foramen is narrow, one can also plan, instead of doing a single burr hole and trying to manage with one trajectory, we have done with two burr holes, one for the third ventriculostomy, and one for the tumor. This is another tumor, the posterior third, where we take the anterior border of the tumor, then draw a line through the foramen Monro and project it on the skull and make the burr hole here, so that one can have a direct access to tumor biopsy. So in cases where we are planning so that in one burr hole it is not possible, we make two burr holes. Like this patient with the one small flap, we make two burr holes so that the neural damage can be minimized. Yeah, this was a video of the biopsy of a posterior third ventricular tumor, but I've already shown this, so I'll omit this video. Now, once one has done the third ventriculostomy, how do you follow up the patient? When you do a scan, the ventricle size doesn't come down. It appears same. It's only third ventricle comes down in 33% of the time, and lateral ventricle comes down in only 16% of the time. So, but what is important is to realize that the sulci has opened up, the cistern has opened up, the PVL has come down. So many times the patients get confused and they get worried that the ventricle size has not come down, but they have to reassure that all the cisterns are opened up, the PVL has come down. It's only in 1/3 of the patients only it comes down. It almost takes 2 to 3 months for the ventricle size to come down. Once you have done that, how do you decide? How do you follow up the patient? It's not once the patient is come for follow-up 2 to 3 months is asymptomatic. It's not we should not tell that you are fine and you not come back. As many times the stoma what you had created can close at a later date also after 1 year or 2 years. So it's important to do a phase contrast MR flow across the third ventricle end of 3 months and then yearly. If one finds that the stoma is closed, one has to redo third ventriculostomy or think of doing a shunt if required. As to this can prevent the many times the sudden deaths which have been reported because of stoma closure which is not detected, and patients come with sudden ICP and sudden death. People compare whether the results of third ventriculostomy is dependent on the experience. Now, Dr. Vogel, he reported his result. In first 33 cases, he had a success rate of only 58%. Whereas in his last 33 cases, he had a success rate of 82%. Experience counts, and the experience of is not only the technique of how you do, but selection of the cases. If you can see here, the risk factor, he has reduced the cases, number of cases he did because of CNS infection or myelomeningocele in his last 33 cases. And even if there is associated intraventricular hemorrhages, he has reduced the number. So the results depends on the technique which you learn over experience and the indications. Again, over the time, we learn that it's only aqueductal stenosis and hydrocephalus due to tumors have the best results, but when it comes to post-infectious or post-myelomeningocele or intraventricular hemorrhages, shunt is equally good as endoscopy. If a patient comes with a shunt, malfunction shunt, do we have to go for a third ventriculostomy? Now, if the cause is due to aqueductal stenosis, it's always worth doing a third ventriculostomy instead of revision of shunt. The outcome rate following third ventriculostomy following a shunt varies from 40% to 80%. But the complication rate is a little higher. But if it's due to, in India where a lot of people, TB meningitis come, in those cases probably revising the shunt probably is not a bad option, as the risk is higher and the shunt-free outcome also is not as good in those cases. When they analyze the causes of early failure of ETV, the most common cause has been, commonest cause of early failure is infection. The second common is hemorrhage. So if you have infection and hemorrhage, and you can keep repeating that, because whenever you have these cases, it's better to avoid third ventriculostomy. Otherwise, the technique will go into disrepute as telling that endoscopy doesn't work. But whenever there's an aqueductal stenosis or due to tumor, the failure is very less. It's like less than 20%. So the best indications are aqueductal stenosis and tumor. So even if you decide the best indication, the 5 years patency rate is only 70 to 80%. That is what the patient has to be told, as most of the time they think that shunt block and third ventriculostomy is a panacea. It is not true. Stoma of third ventriculostomy also can close after 3 to 5 years. Once you have done the ETV, patient also has to be explained that there is the roughly patency rate is 70%. And the early failure within 2 weeks can be due to incorrect technique or due to uh, uh, when you have not perforated the second membrane or you have not seen the basilar artery or improper selection of patient. And the late failure can occur after many months. That is why it is essential that one has to do a CSF flow study across the floor of third ventricle every year. And if one detects there is a change, it's better to do a redo third ventriculostomy. The third ventriculostomy can also fail because of non-absorption of arachnoid granulation despite good flow across the third ventricle. If one finds a good flow across the third ventricle CSF flow and still the hydrocephalus is not resolved, then these are the cases when one has to do a shunt as absorption defect. So the failure of third ventricle can be because of reclosure or narrowing of the ventricular stoma, and this has to be detected early and treated. Otherwise, one can have this sudden deaths. Many child can have will be found dead at home. After doing all this, what is the outcome? The outcome varies depending on the age. In adult patients, the outcome has been almost 77% had good improvement in clinical outcome. But again, it's due to adult onset acute stenosis or tumor associated with hydrocephalus. These are the few papers on the success rate of different in different series of adult patients. It has varied from 70 to 80%. Whereas in children, it's not so good. In children, the 70% the 1 year and the 5 year success rate has been 65 and 52%. So while counseling the patient, they have to be explained that the 1 year outcome is 65 and the 5 year survival is 52, and after 5 years he might need a redo third ventriculostomy and may need a shunt also. In infancy, as you can see here, if it's less than 6 months, the success rate comes down drastically to 30 to 40%. Only and few people for less than 1 year and 1.5 years also have got results of less than 50%. So it's probably better to avoid the third ventriculostomy less than 6 months unless it is due to acute stenosis, where up from even the children from 3 to 6 months also the results are good. Now this is the recent paper in 2016 where they compared this is a multi-center comparison of third ventriculostomy versus shunt for infantile hydrocephalus. And the conclusion in this, there are 115 cases of third ventriculostomy and 43 of shunt, and the age group was 3.6 to 6 months. And the conclusion was that the shunt has a superior success rate than ETV. So at the present stage, if a child comes with less than 6 months, it's probably better to do a shunt than third ventriculostomy, and third ventriculostomy should be reserved for older patients. This is roughly the conclusion of the outcome. If it's less than 1 month child, the success is only 30%. 1 to 6 months is 50%. If 6 months to 24 months, it's 70%. But if it's older child, more than 24 months, it's almost 80 to 85%. Now, endoscopic third ventriculostomy doesn't go without complications. This is a meta-analysis that the meta-analysis of many papers. They say that the complication rate has been quite not bad. Like if the bleeding rate is almost 3%, 3.7%, and the bleeding due to basilar rupture is almost 0.2%. There also has been in complication due to neural injury, like thalamic injury, fornical injury, you have midbrain injury also, and anesthesia-related complications. And in this, 4% had to be abandoned because of they couldn't complete the procedure or because of the bleeding. And like shunt, there are chances of permanent morbidity in third ventriculostomy also. This meta-analysis of almost 3,000 patients, there's a permanent morbidity of 1.44%. Usually it is gaze palsy or loss of consciousness and memory disturbances, as I told you, depending on where you perforate the floor of the third ventricle. If you do more posteriorly, they'll have memory disturbances. If you do more anterior, they have high chance of developing diabetes insipidus. There can be weight gain, there can be precocious puberties also. So one has to be careful and counsel the patient that there can be a lot of hormonal changes, and few people can have memory problems with third ventriculostomy. So the complication rate probably will come down with experience, but this paper they analyzed with series which had less than 100 patients and series which had more than 100 patients. But the overall complication rate did not differ much with the series which had less than 100 or more than 100. And in adults and children also, the complication rate and morbidity rate has not been significantly different. In conclusion, endoscopic third ventriculostomy can be regarded as a low complication procedure with an overall complication rate of 8.5%, with a permanent morbidity of 2.4% and mortality of 0.2%. And if one does in the properly selected cases. In conclusion, success of third ventriculostomy depends on the patient selection, like aqueductal stenosis or tectal tumors or tumor-associated hydrocephalus. However, because of the high rate of failure and complications, ETV in shunt has to be the first line in children less than 6 months, and third ventriculostomy in older children with the above indications. Thank you for your attention. I want to finish here.
Very good, Mark. Thank you very much for a very comprehensive, great videos, great illustration. So I'd like to open up the floor for questions. We're running a little late, but I think we have time for a couple questions. Deepak, would you like to say something? You're muted, Deepak.
Can I? This is Muthukumar. Can I start the discussion?
Yeah, sure.
Okay. Manas, that was a great presentation, very informative as usual. I have a couple of quick questions. One is that regarding the aqueductoplasty, and I've done a few aqueductoplasties recently, but I always have a doubt what's the length of the Fogarty catheter which you insert? Do you measure it in the preoperative CT scan or the MRI scan? How far do you insert the Fogarty? And you did say that you should not dilate the Fogarty more than 2 to 3 millimeters, which most of us do. But is there any guideline as to how far, what the length of the Fogarty? Because if you do not insert it to the entire length of the aqueduct, you are going to only partially dilate the aqueduct. And traditionally, aqueductoplasty works only for short segment stenosis. So, what's your opinion on that?
Means normally we identify the level of the stenosis from the ostium of the aqueduct, from the third ventricle in the pre-op MR. And in the Fogarty, we calculate that what is the distance you have to insert to achieve that. So, before inserting the Fogarty catheter, we make a marking, but to what the distance you have to push it in to achieve the perforating the stenosis as well as dilatation. Usually a mark on the Fogarty catheter with a marker pen. So that's easy to know how much you've gone in.
And do you take any special precaution regarding the cortical entry point for the endoscope? Because if the sheath entry point, there's a sizable corticotomy there, which leads to the formation of a subdural hygroma in some, especially in younger children. Do you adopt any special technique for that? Because when there is a corticotomy opening, in the presence of this is a low resistance path through which the CSF flows out and forms a subdural effusion. It not only forms a subdural effusion, the pressure gradient for the stoma to function also is lost.
Yeah, the opening on the pia is important in both to prevent subdural effusion as well as to prevent subdural hematomas also. If the opening is small, when one is inserting the endoscope, the brain gets pushed and you have remote tearing of the subdural vein, and that can cause subdural hematoma postoperatively. And if it's too big, then you can have subdural effusion as you explained. to prevent subdural effusion. Earlier we used to have effusion, but nowadays what we do is we make it a point to plug the opening of the cortex. We take the pericranium of the where we make the flap and plug it with the pericranium. Or if the child is very thin, if we do not have adequate pericranium, if the skin is very thin, we have used Durafoam to plug the cortical plug so that the subdural effusion can be reduced. We usually plug the cortex.
Yeah.
So,
we usually cut the gel foam, which is dry, and roll it into a cigar form and plug it in so that it swells and occludes the opening. Since
yeah, but
we
the gel foam still is like CSF still goes through that.
CSF does seep through that, but since we have started doing that, we have not had any subdural effusion. So apparently it does work.
Yeah, we put pericranium or Durafoam.
Okay.
Manas, excellent presentation, Manas. I wanted to ask you, which are the thalamic tumors with hydrocephalus wherein you prefer to do endoscopic biopsies? Are there any specific subsets which make you decide, I will not do stereotactic, I will rather go for endoscopic biopsy and ventriculostomy at the same time?
Yeah, if the thalamic tumor, you have three options. If you have a thalamic tumor, either you do a stereotactic biopsy or an open surgery or endoscopic biopsy. If the patient comes without hydrocephalus, we do either a stereotactic biopsy or open surgery. To decide whether biopsy or open surgery, we do a diffusion tractography, DTI, and if the fibers are infiltrated, we do a biopsy. Otherwise, we plan open surgery also. If the patient comes with hydrocephalus, then we do plan do an endoscopic third ventriculostomy as well as biopsy. But many times the thalamic tumors can be very big, where you do not, the whole third ventricle is obliterated, where you cannot do a third ventriculostomy. In those cases, we do a biopsy, we do a septostomy, and put in a shunt also in the same sitting.
And one last question, with the recent availability of international infantile hydrocephalus study results, though the data is quite restricted, we got, I think, 158 cases and less than 30% of the patients were actually randomized. Still, the trial says the ETB success rate is approximately 60% at 3, 6, and 12 months. Now, what is the advice you give to the parents of a child who comes to you with a 3-month-old child with aqueductal stenosis and hydrocephalus? I'm sure a lot of us actually still prefer doing endoscopic third ventriculostomy rather than offering a shunt, even if the child is less than 6 months of age, because of the inherent risk of shunt-associated morbidity. What actually do you practice, and what advice do you give to the parents when the child is quite young with hydrocephalus and aqueductal stenosis?
Yeah, we have not published, but we have analyzed our series where children, the hydrocephalus is due to aqueductal stenosis. 3 to 6 months, we advise third ventriculostomy. But then, if aqueduct we don't find a significant aqueduct stenosis and there is a communicating hydrocephalus, if there is no aqueduct stenosis, we still do a shunt. But even if you do a third ventriculostomy in a child who is more than 3 months, we always warn them that the success rate is only 70 to 80%, and still you may have to go for a shunt. And if they agree for that, then we do a third ventriculostomy. Many parents, they don't want to go for a second surgery; they go for shunt directly. But some parents, they don't want a foreign body; they agree for a third ventriculostomy.
Thank you, Manas. Thank you.
Okay, great. We're running a little late, so I'd like to wrap it up. Thank you, Manas, for a great talk, and we look forward to hearing more from you. And thank you for all the panel. So, Jimmy, let me just wrap it up before we start the next one. Thank you very much.